So as Azim says, my name's Georgie and I'm currently an internal medicine trainee at St Mary's in London. I have a clinical interest in oncology, and over the next few minutes we'll just be talking you through the main things you need to know about skin cancer and some particular hints and tips to get you through your exams. So as you know, the three most common types of skin cancer are basal cell carcinoma, squamous cell carcinoma, and malignant melanoma. For each in turn, we're going to be looking at the causes and pathophysiology of these conditions, how they typically present, their signs and symptoms, and how to approach the assessment of suspicious skin lesions, thinking about how we investigate and then go on to manage these conditions. Throughout each of these conditions, I will be trying to highlight key things that may crop up in exams and get you those extra marks in your final exams. So just to step back for a moment before we start looking at these three main conditions, I just want to give you a broad overview of how to approach a skin lesion. So just things to consider are thinking about where exactly are these lesions, or is this lesion? Are they in a particularly photosensitive place? Are they on the face, for example? What colour is the lesion? Is it skin coloured, or is it pale? Is it black in colour? All these things will begin to give you some valuable information. What's the size and shape? What are the margins like? Are they well or poorly defined? And are there any other features of note? Are there any appearances of excoriations, for example? So with that in mind, we're going to move on to the first topic we're going to discuss, which is basal cell carcinoma. So basal cell carcinomas are also known as rodent ulcers. They are the most common type of skin cancer, accounting for 75% of skin cancers in the Western world. They are more common among men compared to women, and patients may often develop multiple primary tumours over time. They tend to invade locally, if at all, and rarely metastasize to distant sites. So just to give a little background about the pathophysiology of basal cell carcinomas, these tend to arise from the basal cell layer of the epidermis, which is the uppermost layer of the skin. The cause is multifactorial and often is a combination of environmental factors, the most important of which is excessive sun exposure, and also combining that with a number of genetic factors. Typically, however, it's UV radiation that triggers DNA mutation within tumour suppressor genes, resulting in the development of these tumours, as I say, which develops in the basal layer of the epidermis, the upper layer of the skin. Here you just see a picture of the basal cell carcinoma again in this top uppermost section of the skin. So thinking about risk factors, so who is at risk of developing a basal cell carcinoma? So it's important to say that both increasing age and being of the male gender provide a degree of risk. Clearly, exposure to excessive sunlight is also can also be potentially damaging. This may be through the use of regular sunbeds or sun exposure without protection from high factor sun creams. People with fair skin are also at risk, and other patient factors such as immunosuppression. Are they a transplant patient, for example? These other elements are also important when you're taking your detailed histories. So moving on to clinical features. Now this is of course really important because this is as junior doctors where you'll be on the ward, you'll be examining patients on a day-to-day basis, and it's these signs that you can keep an eye out for when you're seeing patients who may incidentally have a suspicious lesion. So for a basal cell carcinoma, typically these grow slowly over several weeks to months, or even longer than that. They tend to be skin coloured or translucent, and can vary widely in their size. They may ulcerate or bleed or cause some degree of irritation on the skin. Now, there are a number of different types of basal cell carcinoma. I don't want you to feel you need to be bogged down in all these details, but I just want to highlight to you the most common type, which is the nodular type of basal cell carcinoma. Now, these tend to begin as a sort of simple nodule, which then spreads outwards and leaves a central depression, which gives it appearance of having rolled edges. So lesions typically pearly in colour with rolled edges, and telangiectasic vessels are the most typical lesions you will see for a basal cell carcinoma. Of course, there is variability, but to have the most typical image in your mind, I think, is really useful. In an exam scenario, if you see a question that discusses a pearly, flesh-coloured lesion with a central depression, you need to be thinking, is this a basal cell carcinoma? Because it probably will be. And here is an image of what we were just discussing. So as you see these red lines which show the vessels and the translucent colour and the pearly appearance. And here again, the colour and the description. Hopefully now in your mind you'll be able to visualize these going forward. So when assessing a patient with a suspicious lesion, like any presenting complaint, you'll start with your structured history. And of note, these are typically slow growing and often don't present with that much in the way of systemic features. You will examine them and also look at the surrounding skin, and then think of the next steps. And in this case, we'll be considering a biopsy. So in terms of a biopsy, these typically will demonstrate nodules in the basal cells, as we discussed on the previous slide. Now, there's a number of ways of managing basal cell carcinomas. The first line is surgical excision of the lesions. This is typically done with a 3 to 5 millimeter margin around the lesion. Following this, further surgery can then be performed if it's later found that they didn't have clear margins on the excision. Different types of surgery can also be used. So this next one is actually performed under microscopy. And this is particularly useful for cosmetically sensitive areas. So this is around the eyes and also around the lips. Other options include cautery of superficial skin. This is a superficial skin surgery under local anaesthetic. It's good for smaller nodular or superficial basal cell carcinomas. It doesn't require stitches and heals via secondary intention. Other options include cryotherapy, which is a treatment via freezing with liquid nitrogen, which then causes a blister, or alternatively some topical treatments which work by modifying the immune response or have a cytotoxic agent within them that is used on the skin typically twice daily over several weeks to have an effect. Now, if these options aren't suitable for the patient, alternatives do include radiotherapy, but very much the first line is surgery. That's the optimal treatment. So just to summarize what we have just discussed for basal cell carcinoma, these are the #1 most common type of skin cancer. Typically, they grow slowly, present as pearly coloured lesions with rolled edges and central depressions, and are managed first line with surgery. The prognosis for this is tends to be very good, with metastatic spread occurring on only very rare occasions, with a recurrence rate postoperatively of less than 2%. So it's really got a very good outcome if it's treated appropriately. However, it's important to note that local destruction can occur, and that's why it's important that they are still treated as promptly as possible. So now we're going to go on to look at squamous cell carcinomas. These are the second most common type of skin cancer and account for about 20% of non-melanoma skin cancers. They arise from the epidermis, the uppermost layer of the skin, and extend down into the dermis. They're derived from cells that make keratin, the protein that makes up skin, hair, and nails. And in a similar way to basal cell carcinomas, they can occur from damage from the sun, from UV radiation. Local invasion often occurs, but again, widespread metastatic disease is less common in comparison to something like melanoma, which we'll go on and discuss in a few minutes' time. A few risk factors to consider are many of which have an overlap with basal cell carcinomas. In that, I mean exposure to sun, increasing age, and particularly males as opposed to females are at most at risk. Actinic keratoses are also important to note. These are scaly spots which are found on sun-damaged skin. These are considered a precancerous condition, and therefore it's important we treat these to avoid them going on to develop into squamous cell carcinomas. Smoking is a key risk factor, and that's something you will have elicited when you've taken your social history, when you've been clerking the patient. Chronic ulcers are also an important thing to consider, and they carry a risk of developing into squamous cell carcinoma. So it's important in both your history taking and your examination to consider this. So moving on to the clinical features of squamous cell carcinoma. These typically will develop as a scaly red patch with irregular borders. They often will bleed or crust over, and may have arisen from roughened, irritated skin. Another way these present is as an open sore or an ulcer that persists for several weeks. And if that is the case, that should increase your suspicion for something more sinister going on, such as a squamous cell carcinoma. So here we see an example of an SCC. Here you will be able to visualize in the center of the screen the crusted nature of the lesion, and you can see that there the irregularity of the borders and the variability of the color within this image. Here again, you see this similar features of a crusting and a poorly defined lesion, which again is quite typical of these squamous cell lesions. So, like basal cell carcinomas, you will often, through pattern recognition, be able to diagnose these clinically based on your history taking and your clinical examination. But biopsies are important, particularly to confirm the diagnosis and to identify what type of squamous cell carcinoma you're dealing with, as this in turn will help direct and inform how you are going to manage this patient who's in front of you. So in terms of the management, surgical excision again is the most important thing to consider. But there are other options, as touched on with basal cell carcinomas, depending on the location of the lesion and other patient factors, and their suitability to surgery. All these factors will play into the decision as to how best to proceed with your management. Again, for patients where operative procedures are less suitable, radiotherapy can always be considered both as an alternative or as an adjunct to surgery. So overall, the cure rate with appropriate treatment of squamous cell carcinoma is over 90%, so a very good prognosis. Recurrence is uncommon, and widespread metastatic disease doesn't happen very often, though the prognosis is slightly less good than with basal cell carcinomas. And just a quick note on prevention. So recommending protection from the sun with high factor sunscreen, not being exposed to sun too much, and certainly avoiding getting burned, all very important. And also early identification and treatment of known precancerous skin conditions is really, really important to prevent the condition developing in the first place. So far we've discussed both the most common type of skin cancer, basal cell carcinoma, and squamous cell carcinoma, which is the next most common type of cancer of the skin. Finally, what we're going to do is consider malignant melanoma. Now, this is less common compared to the other two I've just discussed, but most certainly is more serious and is associated with earlier metastatic disease and poorer outcomes. So in terms of the epidemiology, the incidence is increasing, and this condition often affects patients of a younger age group. And sun exposure, as I'm sure you're clocking on now, is incredibly important. The highest rates of melanoma globally are in Australia and New Zealand, as I'm sure you can imagine. 1 in 15 white-skinned New Zealanders are expected to develop melanoma in their lifetime. And recent data shows just how this incidence of melanoma is increasing, with some records finding it the third most common in males after prostate and colorectal cancer, and in females after breast and colorectal cancers. So a really important condition to be familiar with. So I'm just going to take a minute to discuss the pathophysiology of melanoma. So melanoma develops as a result of uncontrolled growth of melanocytes, which are the pigment cells within the skin. So normal melanocytes are found within the basal layer of the epidermis, the outer layer of the skin. And melanocytes produce a protein called melanin, which protects the skin cells by absorbing ultraviolet radiation. Now, non-cancerous growths of melanocytes result in moles, or what we call benign melanocytic nevi and freckles. The cancerous growths of melanocytes result in melanoma. So these can both be in situ, and what we mean by that is that the tumour is confined to the epidermis or the epidermal layer. Invasive melanoma, where the tumour has spread down into the dermis, or metastatic melanoma, if the tumour has spread to other tissues. It can be extremely serious, and until recently was associated with an extremely poor prognosis. Though, as I'll touch on in the later slides, that has changed in recent years, and the future is looking much brighter in terms of prognosis from this condition. So, just briefly going to touch on the risk factors for melanoma. So, having a previous history of skin cancer in both the patient or a family history of skin cancer, of melanoma, or a different form of skin cancer is very relevant here. Age is a factor, sun exposure is a factor. Personal characteristics, such as patients who have pale skin, patients with red or blonde hair, who typically have fairer skin, is also a risk factor. Having multiple moles or moles with atypical appearances is also important. Partly because in these individuals, changes within the moles may not be detected as readily. Now, I'm just going to take a moment to go through this slide, which is quite a busy slide, but I think it's important as this basically covers the four key types of melanoma that you need to know about. And I think this is definitely something that crops up in exams. So I just wanted to make sure we took a moment to discuss this. So the most common type of melanoma is called superficial spreading, occurring in 70% of cases. These typically affect younger people and are found usually on the chest, arms, or legs. They have an irregular pigmentation, and in subsequent slides, I'm going to show you some images to help you visualize this a little bit more easily. The next most common type is called nodular, and these typically grow very fast and in general are very aggressive. It's a very aggressive type of melanoma. They often present in middle age and are often described as pigmented nodules and have a tendency to bleed or ulcerate. So superficial spreading is the most common, with nodular is the second most common. After this, latigo maligna is less common. It's described as a melanoma in situ and grows slightly slower compared to the others. It tends to present in older people in photosensitive areas particularly on the face, and are often superficial and flat in appearance. In contrast to these first three, acral legionus is the fourth type, and this is the rarest of them all, and typically it presents much later. Now, the key thing to remember for this type of melanoma is that they typically affect the hands and the feet. So the hands and the feet is what you need to remember for this type of melanoma. Typically, they would also involve the nails or the nail bed, and that's a very common place for these cancers to present. There's a different, typically as well, they affect African American, and Asian patients. So often those with darker skin have a tendency to develop these types of melanoma. I hope you found that useful. I think that's quite an important information for your exams, that slide. Right, so now I'm just going to cover some clinical features, and there's a few ways in which we can assess this. So first of all, thinking of the symptoms and the signs. So again, dermatology is very visual, so it's a lot of it. Your skills will improve through pattern recognition and looking with a very inquisitive eye at these lesions will help you build your repertoire of knowledge and make it easier to recognize these the more you see them. But key things to consider are both systemic features, such as do they have symptoms of lethargy or weight loss, change in appetite, for example, and then skin features of the lesion, in particular, changes in the size or shape of the lesion, changes in sensation, considering whether they're bleeding, ulcerating, crusting, itching, all these different elements. And thinking of other signs, looking at the borders, looking at the symmetry, assessing the lymph nodes, will begin to build your knowledge as to what type of lesion this might be, and whether it's potentially one that we need to act on more quickly, or one that's of less clinical concern. There's two, I'm now going to discuss two sort of approaches to assessing these lesions. So this is one, this is more a referral tool actually, in terms of if you score 3 or more from the criteria you see on this slide, then that is deemed suspicious of this skin lesion, and therefore we would recommend that you made a referral to dermatology as a 2-week wait, so that they could have an urgent assessment. So key things which would score 2 points would be changes in the size, shape, and colour of the lesion. And then minor features which would score 1 point is a large diameter of the lesion over 7 millimeters, whether there's any evidence of inflammation, oozing, or changes in sensation. This is the other approach you can think about, which is the ABCDE approach, which you may well have heard of already. Now, I think this is quite a useful one actually, because it's a bit easier to remember. And you can think asymmetry. Is there any evidence of that? Borders, are they well defined or are they poorly defined? Is there variability in the colour of the lesion, and what's their size? And in terms of is this lesion evolving? Is it changing in size or shape or features over time? So in terms of correlating features of a skin lesion to outcomes and risk of metastatic spread, the key feature is the Basal thickness, which simply equates to the depth of the lesion. So the deeper the lesion, the more likely it is to metastasize, and the worse the predicted prognosis. That's also, I think, an exam favourite, Basal thickness. So once we've considered these lesions, and a diagnosis has been made, the staging will be done, which will help guide our further management. And the TNM staging is typically used for melanoma. Again, depending on the depth of the tumour is very, very important, whether there's involvement within the lymph nodes, and whether the disease has spread to distant sites. In all cases, ideally, an excision biopsy will be done, where the lesion will, if possible, be removed completely. Other things to consider is that the lymph nodes need to be tested to see if there's any involvement there, because this will go on to dictate the degree to which we need to treat the cancer aggressively, and whether or not they may go on to require systemic anti-cancer therapy. In those with more severe disease, we often do genetic testing to look for certain markers that will enable us to direct our treatments in a more targeted fashion, in terms of immunotherapy, for example. But you don't need to worry about those details at this stage. So this slide is simply just to say that the deeper the lesion, the greater the excision margin is required. You don't need to worry about the numbers, just the principle. So the deeper the lesion, the wider the local excision needs to be done. So in terms of the management, it is like in every case, it will be graded depending on the location and the spread of the disease. So surgery is an important factor for this management, considering the lymph nodes, will they need to be removed? And in more metastatic settings, we'll be considering targeted therapies, if particularly if things like the BRAF mutation has been identified, and other immunotherapy or cytotoxic chemotherapies may also be appropriate. Thinking of complications of these treatments or complications of this disease, we can think about the results and the consequence of surgery, the risk of local disease recurrence or the burden of metastatic disease, and also the impact of or potential complications that can occur from treatments themselves. So in the case of systemic anti-cancer treatments, things like chronic fatigue, organ damage, neuropathies are all potential complications of having treatment. So in terms of prognosis, the earlier the disease is detected, the more likely we are to be able to intervene before the disease has spread, and therefore the outcome is likely to be better. Equally, the smaller and shallower the lesion, thinking of the Basal thickness, the better the prognosis. And again, this is just to give an example to show that 5-year survival is better in shallower compared to deep lesions. Here is a picture of a malignant melanoma. Here you see, if we think about how we would go and assess a lesion, you can see here that there's asymmetry within the lesion. The borders are irregular. There's variability in colour. We don't have any, we can't assess the size here, but you can measure the diameter to see, is it a large lesion over 6-7 millimeters? And has it changed over time? These are the questions you'll be asking yourself. And again, here's another suspicious looking lesion that you would be most likely wanting to refer as a 2-week wait to a dermatology unit for further review. So thank you all very much for listening. That takes us to the end of the webinar tonight.